Last but not least, in Chapter 14, we're going to be talking about antidepressants, psychomotor stimulants, and lithium. So, starting with different types of depression. So, depression can be exogenous or reactive. It's caused by external factors. Major depressive disorder originates from within the individual. So the difference between the two, there's things that happen in life such as death, unemployment, divorce, etc. that can cause a reactive depression. You're reacting to something that's happening outside of you. Major depressive disorder is more serious and requires psychotherapy and drug treatment. This type of depression might not stem from any resource. It might just occur even if the person is at a great point in their life. Depression is linked to low levels of norepinephrine and or serotonin. So those are going to be the mechanisms of action of our drug, is to increase those neurotransmitters. In some cases of depression, there are alternate periods of hyperexcitability and elation known as mania. Individuals who experience those alternating cycles of depression and mania are classified as manic depressive. This is also known as bipolar mood disorder. So bipolar disorder can be a cycle of depression and mania. Drugs used to treat depression usually increase the level of norepinephrine and serotonin. The major classes include serotonin reuptake inhibitors, or SSRIs, atypical SSRIs, tricyclic antidepressants, and monoamine oxidase inhibitors. So SSRI stands for selective serotonin reuptake inhibitor, just in case you were wondering. So selective serotonin reuptake inhibitors block the reuptake of serotonin, so that allows more serotonin to hang around. If you remember, depression is usually a case of low serotonin, so if we allow it to hang around for longer, we're doing our job. This increases the amount of serotonin available to work on the system. And SSRIs have become the major treatment for depression. They're used pretty widely. They also are effective for many anxiety disorders and post-traumatic stress disorder, as well as obsessive-compulsive disorder. All of the SSRIs listed cause GI disturbances, nausea, diarrhea, dry mouth, and anorexia. They've also been associated with sexual dysfunction, most commonly reduced sexual interest and delayed orgasm. And other CNS effects include headache, nervousness, insomnia, and tremors. Sometimes the side effects of these medications can be too intense for a person to be able to take them. So oftentimes we'll try one or two before we really find the one that works. So on slide 10, it's a list of the SSRIs that are available out there. Some names that are on there: citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. The brand names might sound a little more familiar to you because a lot of us have had experience with these medications. Maybe a friend is on it, maybe our parent might be on it. So atypical SSRIs block the reuptake of serotonin and act on other neurotransmitters as well. Like the SSRIs, they have little effect in blocking cholinergic, adrenergic, or histamine receptors. Atypical SSRIs listed on the chart on slide 12 include bupropion, desvenlafaxine and venlafaxine, trazodone, nifazodone, and mirtazapine. So the other neurotransmitters that they might affect include norepinephrine and dopamine. Sometimes in pharmacy we refer to these drugs as SNRIs, selective norepinephrine reuptake inhibitors, because sometimes their effect on norepinephrine is greater than it is on serotonin. Tricyclic antidepressants. These are named tricyclic because they have a three-ring structure, and the main action is to block the reuptake of norepinephrine and serotonin into the neuronal nerve endings. They produce varying degrees of sedation, anticholinergic, and alpha-adrenergic effects, so we'll want to keep that in mind as far as their side effects. A list of them is on slide 14. Some you might have heard of before. Amitriptyline is really commonly used, also called Elavil. Some of the other ones, clomipramine, desipramine, nortriptyline, doxepin, and imipramine. You can tell they all kind of sound familiar or similar to each other. Those are all commonly prescribed, but amitriptyline is definitely the most prescribed out of that class. So drug interactions listed on slide 15. Has interactions with alcohol, of course, because it can cause increased sedation. It can increase the possibility of seizures when taken with anticonvulsants. And as far as the anticholinergic side effects, the pretty common ones, dry mouth, constipation, urinary retention, and blurred vision. And of course, MAO inhibitors interact with just about everything, so we want to avoid taking MAO inhibitors with our tricyclic antidepressants. Monoamine oxidase. You've heard a lot of interactions with these class of drugs over this module. Finally, you're going to hear about them. Monoamine oxidase is an enzyme found in adrenergic and serotonergic nerve endings. The normal function is to break down norepinephrine and serotonin. So if we can inhibit that, we prevent the breakdown of norepinephrine and serotonin. So monoamine oxidase inhibitors prevent that breakdown. Monoamine oxidase is mostly found in body cells, but particularly in those adrenergic and serotonergic nerve endings. Okay. In mental depression, there appears to be an abnormal decrease in the levels of norepinephrine and serotonin, and drugs that block MAO or MAO inhibitors prevent the norepinephrine and serotonin from being destroyed. So, there are many drug interactions, which is why, and there's also food interactions, which is why we tend to stray away from these. It's usually a last-ditch effort for somebody who has failed a lot of other treatments. So disadvantages of MAOIs. Dietary restrictions, wine, beer, herring, certain cheeses. Got to be careful with what these people are taking in. The tyramine content of our foods is what we're looking at when we think about MAOIs. Adverse effects, dry mouth, urinary retention, hypotension, restlessness, and seizures. In addition, certain sympathetic drugs that are used in the treatment of cold symptoms, such as bronchodilators and decongestants, also interact with MAO inhibitors. So, the ones that are commonly used are Marplan, isocarboxazid, nardilphenolzine, and Parnate, which is trancypramine. Sorry. Some of these, the MAO inhibitors are actually probably one of the harder classes of drugs to say. So, again, thank God they're not commonly used. So, psychomotor stimulants, our last class, I think, except for lithium, that we're going to talk about. Psychomotor stimulants include the amphetamines and other closely related drugs, which are really not classified as depressants. The role of treatment in depression is extremely limited. They're usually used during the first 2 weeks to elevate mood and increase psychomotor activity. Amphetamines are also used to control narcolepsy and hyperkinesis in children. You're also familiar with them being used for ADD or ADHD. Amphetamines stimulate the reticular formation, which increases wakefulness and alertness and reduces the number of attacks of narcolepsy. They stimulate CNS by increasing the activity of norepinephrine and dopamine in the brain. And there's several different mechanisms of action of the way they do this. They directly stimulate norepinephrine and dopamine receptors. They stimulate the release of norepinephrine and dopamine from nerve endings, and they inhibit the reuptake. So sort of a threefold punch there. So the disadvantages. These are controlled substances, so we have problems with drug tolerance and dependence. They increase the activity of the sympathetic nervous system, which can lead to dry mouth, heartbeat, rapid heartbeat, increased blood pressure, restlessness, and insomnia. Toxic doses can actually agitate psychosis or lead to a paranoid type of psychosis, so we got to be careful there. And psychomotor stimulants that you'll hear used, amphetamine, Focalin, which is dexmethylphenidate, dextroamphetamine, which is Dexedrine, methamphetamine, which is Desoxin, and methylphenidate, which is Ritalin. Lithium, last but not least. Lithium interferes with nerve conduction. It's technically a heavy metal. It decreases the excitability of nerve tissue, and it's administered as a salt. Escalith or Escalith CR are the most commonly used ones. It usually requires about 1 to 2 weeks to see an effect. So lithium and sodium, where was I going with that? We're going to leave it at that. Just remember that it interferes with nerve conduction. Side effect includes nauseousness and tremors, and it does require you to have an adequate intake of sodium to properly excrete the lithium. If you have a lithium buildup in your body, it can be toxic. So side effects, we talked about nauseousness, tremors, therapeutic doses. Overdose leads to vomiting, diarrhea, drowsiness, loss of equilibrium, ringing in the ears, and frequent urination. And at toxic levels, heart and kidney damage can occur, leading to arrhythmias and nephritis. Lithium is category D for pregnancy and should never be used in a pregnant patient. Any questions on this chapter, please feel free to get in touch with me. And if not, guess not. Tell me I didn't just erase. Okay, I didn't just erase that. I guess I'm just taking pictures. Any questions, please feel free to get in touch with me. Good luck for the rest of your time here at Mildred Elley, and it's been a pleasure teaching you guys. Thank you.